Good afternoon, everyone, and thank you for joining us today. I'm Nivi Patel, Primary Care Lead for Social Prescribing at CCH-OHT, and hospitalist working at the Oakville Hospital. I'm excited to welcome you to our webinar from the Lifestyle Medicine and Social Prescribing series. This is a bi-monthly webinar initiative designed to support all of us in primary care with evidence-based practical approaches to incorporating lifestyle medicine into our practice while also addressing social aspects for caring for our patients. Today's webinar focuses on sarcopenia and osteoporosis. I'm pleased to welcome Dr. Manju, who is joining us to explore the important relationship between muscle health, bone health, and fracture risk, which is an increasingly relevant topic as our population ages and as we focus more on prevention and healthy aging. We will explore the multidimensional contributors to osteoporotic fractures, including the important role of sarcopenia, and examine the interconnected sarcopenia-osteoporosis cycle and its clinical implications. Thank you for joining us today, Dr. Manju. Just a little bit about Dr. Manju. He's an orthopedic surgeon licensed to practice in Ontario. He completed his orthopedic residency at the University of Western Ontario in 2009 and achieved fellowship status the same year. Dr. Manju further specialized in orthopedic traumatology during his fellowship training. He's had training in orthopedic trauma and foot and ankle surgery at the University of Western Ontario. He's also completed a master's in medical biophysics with a focus on lower limb trauma. He practices at Joseph Brand Hospital in Burlington, Ontario, since July 2011, focusing on complex reconstruction due to orthopedic trauma, with particular expertise in foot and ankle surgery. He's also an examiner for the Royal College of Surgeons of Canada, and as an assistant clinical professor at McMaster University, he contributes to education and training future orthopedic surgeons. He's also widely published in peer-reviewed journals and textbooks with a focus on orthopedic trauma and osteoarthritis. He's also an active member of the Orthopedic Trauma Association and serves as an examiner for the Royal College of Physicians and Surgeons of Canada for orthopedic surgery qualifying examinations. So welcome, Dr. Manju. Thank you so much for taking the time out of your busy schedule to be here with us. Before we get started, just a few housekeeping points. It would be great if all of you could mute yourselves so we could minimize background noise. And I'd also ask that you post your questions in the chat or ask questions at the end. We will have time reserved then. There will also be a brief evaluation form in the chat, and it would be wonderful if you could fill that out as well. Thanks for being here again, and I'll turn it over to Dr. Manju now.
Yeah. Hi, everyone. So really, thanks for having me. I really appreciate the opportunity to chat with you guys. Just Nivi, I just want to make sure everyone can see these slides and everything's coming over clearly.
Yeah, I can.
Okay, perfect. So I'm assuming if you can see it, everyone else can see it. Okay. So, as Dr. Patel was saying, like today, I wanted to chat with you guys about sarcopenia and osteoporosis because it's something that, that we don't always pay attention to, but it's really important. I see sarcopenia as a precursor to osteoporosis, and it's a intervention point that we don't really think about. But I think it's one of those really low-hanging fruit that I think that if we were to stop and kind of give it a little more attention, we can really prevent the downstream effects of osteoporosis. And we'll get into it a little bit. I have nothing to disclose. So really, we want to start by what do we want for our patients, right? Like, for our patients as our patients get older, right? So, and what do they want for themselves? And it's a range. Some patients are very active and they want to keep running marathons. They want to play pickleball. They want to live a very full life. Some people just want independence, mobility, staying at home, staying in their own home, like playing with their grandkids, right? And I think that I think we have been, and I'm guilty of this as well. We've kind of lowered our expectations for our elderly patients. Like we kind of accept in our mind that they're going to decline. Like they're not going to be able to play tennis. They're not going to be able to do their 10,000 steps a day. And and we see it as a normal part of aging versus a modifiable uh, uh, effect that we can change. So one of the things we want to look at is lifespan versus health span, right? So we know the average lifespan in Canada is 80 to 82 years, depending on whether you're male or female. But the average health span is 70 to 71. So health span is the number of years we spend free of chronic disease and disability. So in Canada, it means that there's 10 years of suboptimal health that the majority of our patients are living with. And this functional decline is not inevitable, right? And there's a lot of data that supports that we can modify these effects. There's some causes that we can't modify, like cancer, heart disease, stroke, but osteoporosis is a major driver. Sarcopenia and osteoporosis are major drivers of this functional decline, and it is preventable.
Sorry to interrupt.
Yeah.
We're just not seeing the slides move forward.
Oh, that's interesting.
So it's still showing up on the first page or the first slide.
Okay.
Okay, now we're seeing.
You can see
now it's the disclosures. Yeah.
Okay, so maybe what I'll do is I won't put it on the presentation view. I'll just leave it like that, and you can see that.
Yeah.
Okay. All right. Perfect. Perfect. And again, please stop me if there are any issues that. Right. So here's a clinical reality about osteoporotic fractures. As surgeons, as orthopedic surgeons, we're really good at getting the bones to heal, right? We can get bones to heal almost perfectly, but we can't get we can't get our elderly patients back to where they were, right? And that's because the bones heal, but the muscles lag behind, and they lag behind significantly. So bones will heal by 3 months, but the muscles don't get back to where they were even at the 6-month mark. And that's been my experience in my practice as well. So we see that patients are not getting back to where they were. So, if they were running marathons before they fell, they might get back to jogging. If they were walking, they may get back to using a cane. And that's, obviously that's a range. Some patients are very, very motivated, but in general, we see, 1 or 2 steps of functional decline. And a big part of that is the sarcopenia that develops after the fracture, right? So what happens is patients are immobilized or they're non-weight bearing after the fracture, and there's this rapid muscle atrophy that develops that stops them from getting back to their former self, right? And a big part of that leads to a transition to long-term care, which is not what they would want for themselves, not what we would want for ourselves, not what we want for them. Another issue that we don't really talk about much is mortality after a fragility fracture. So, this might surprise people, but after a myocardial infarction, the mortality rate is 15%. But after a fragility fracture, it's 25%. So we're looking at something that's even higher than a heart attack, but it's still something that doesn't get a lot of attention. And a big part of that is that we're not treating them. So after an MI, 80% of patients are on adequate treatment. Prior to a fragility fracture, only 6 out of 20 patients are being properly treated. And then after the fracture, that goes up to 70, right? So there's a huge gap there that we're looking at, right? And so these fractures, they come at a cost, right? Quite literally, they come at a cost, and that cost to the healthcare system is it's depending on the fracture. So it's $16,000 for wrist fracture, $67,000 for a femur fracture. But on average, it's about $37,000, right? So what that means is 10 years ago, the additional health cost to Ontario was $720 million and $2 billion to Canada. So 10 years ago, that was the number. Right now, it's probably even higher due to inflation. So you add that to the burden of chronic disease. So the Ontario Hospital Association published a study which showed that by 2050, we would no longer be able to provide universal health care to our children and grandchildren. And a big part of that is the burden of chronic disease, and fragility fractures are a big part of that. And, to me, that I consider that low-hanging fruit. So what is sarcopenia? So sarcopenia, it's a progressive disorder of skeletal muscle that results in decreased mass, strength, and function of the muscle. So muscles have multiple functions. The main ones that we're aware of is force production, right, which allows us to move, allows us to lift, and power and reactivity. So that one is very important, but somewhat overlooked, because power and reactivity allows us to self-correct. It allows us to maintain our balance, and it prevents, it's a big part of what stops us from falling, right? So what we see is that, patients who are in their 50s and their 40s, somebody knocks them or they trip, they're able to self-correct. As we get older, as the muscles get weaker, we're not able to correct as much. So a lot of these patients, they'll actually almost fall in slow motion, right? Muscle also has an important metabolic and endocrine function. So muscle is one of the primary storage sites for glucose. And it actually plays a really important part in glycemic control, as well as lipid profiles. And on top of that, because it's the main store site for amino acids, it's really important in the stress response. So what we see is that patients that have like a big, that are very muscular, they will respond, they'll recover better from trauma, recover better from surgery, recover better from strokes, from heart attacks, compared to patients that are sarcopenic. Right? So what we need to think about is muscle mass. So muscle mass equals independence. It's the foundation for mobility and the foundation for resilience. What happens with time is that, once we hit 30, we start losing our muscle mass, and it happens and occurs like 3 to 8% per decade. But by the time we hit 70, that jumps up to 10% per decade, which is huge when that compounds, right? And what's more alarming is that strength declines 2 to 5 times faster than muscle mass. So how does sarcopenia relate to osteoporosis? So really comes down to Wolff's law, which is first described in the 1800s. So what it shows is that bones adapt to the mechanical load placed across it. So anything that causes bending or twisting of the muscle of the bone generates a piezoelectric force, which causes the bones to lay down, causes the cells to lay down new bone and decrease bone resorption. So we end up with physiologically thicker cortices that have the same modulus of elasticity as normal bone. So basically healthier bone. And you can imagine that muscle is a primary generator of strain across that bone. And so when we have strong muscles and we have stronger bone, right? I mean, that's the crux of it, really, right? So sarcopenia is somewhat silent. So osteoporosis we can measure and we can look for, or we have been able to measure and look for effectively, but sarcopenia, unless we go looking for it, is silent. So what is osteoporosis? We all know that osteoporosis, again, is a progressive disorder of skeletal tissue where we get decreased bone mass, changes in microarchitecture of the bone, resulting in increased fragility and high risks of fractures. So you can think of it as primary versus secondary. So primary causes of osteoporosis include what we see with postmenopausal patients in general age-related osteoporosis, osteopenia. There are multiple secondary causes such as endocrine, inflammatory, drug-induced, renal, but I want to focus on the primary osteoporosis. So in women, as they lose estrogen during menopause, there's a shift in activity there's a shift in bone metabolism where it shifts from increased osteoclasts, which break down the bone, and decreased osteoblasts, which build the bone. So basically, as estrogen falls, the bone resorption increases, the bone building decreases, and that results in a rapid loss of trabecular bone. With men, we have a more gradual decline in testosterone. And testosterone has a direct anabolic effect both on bone and muscle mass. So, you're getting as the testosterone decreases, muscle mass is decreasing, and there's less mechanical strain across the bones. And also, testosterone gets converted to estrogen, which also has those same protective effects. So this is kind of the thing that we want to talk about, the osteoporosis, the sarcopenia osteoporosis cycle. So what happens is patients fracture, and then they become somewhat sedentary, partly because they're immobilized, they're not allowed to weight bear, pain stops them from using their stronger muscles. And so those muscles start wasting, and they waste in a way that's more rapidly accelerated than we see with average wasting. And as those muscles waste, the bones become more osteopenic, and you lose that muscle power and reactivity. And so now you're at increased risk of the next fall. So what happens is, like you can imagine, you're much higher risk of refracture, and the data is pretty clear that 1 in 5 patients will fracture again in 2 years. And so really our best intervention is to prevent the first fracture, identify it early, and treat both the sarcopenia and the osteoporosis. So how do we screen for sarcopenia? So the European Working Group has a 3-step approach. So one is screening for it. So we look at grip strength. So 27 kilograms and less than 27 kilograms in men, less than 16 kilograms in women is considered an indication for screening for osteoporosis. The DEXA scan is kind of the gold standard for appendicular muscle mass. And then once you've diagnosed this, there's physical tests that you perform to determine the severity of the sarcopenia. So gait speed less than 0.8 meters per second, and a sit to stand more than 12 seconds. So treating osteoporosis, so 2 pillars for treating osteoporosis is progressive resistance training and protein and supplementation intake. So for protein, we're looking at 1 to 1.2 grams per kilogram per day, and that combined with progressive resistance training builds muscles, maintains strength. All right, so this is a really striking slide that I think that really brings it home. So on the left, you see this is a cross-sectional image of a thigh of a 40-year-old triathlete. In the middle, we have the cross-sectional area of a sedentary 70-year-old. So you can see that the muscles are decreasing and there's fatty infiltration. So that's what we call sarcobesity. But then on the right, we look at the muscle cross-sectional area of a 70-year-old athlete. And when you look at the 40 and the 70, like they're very similar, right? So what that tells you is this age-related decline is not inevitable, and it doesn't have to happen. So the Lift More trial done in Australia showed that high-intensity resistance training under supervision not only increased bone mineral density with cortices that are similar to healthy bone, but it also increased strength. So what that shows is that as our patients get older, they can lift hard and they can lift safely under proper supervision. Beyond lifting, we also want to work on core strengthening, proprioception, foot speed drills, because what that does is it decreases fall risk, increases the ability to balance, increases ability to correct once you've lost balance. So that's a very important part of it. Diagnosing osteoporosis. So we look at, history, physical exams. We look at things like age, sex, body mass index, prior fractures, parental history of hip fractures, smoking, cortisone, rheumatoid arthritis, other secondary causes. Physical exam, we're looking at low body weight, wall to occiput distance, rib to pelvis distance, teeth count, and also self-reported changes in vertebral alignment. So DEXA scan is kind of our go-to test. So a normal scan is considered more than -1. Osteopenia is -1 to -2.5, and osteoporosis less than 2.5. It's really important to know that 70% of these fragility fractures actually occur in the osteopenic range. So by the time they're osteopenic, we've somewhat missed the boat for intervention. So treatment is based on a FRAX score, which determines your risk of fracture in the next 10 years. So patients that are low risk, just in broad terms, if you're low risk, you reassess later, but you want to emphasize that lifestyle modification, strength training, nutritional strategies. High-risk patients, we start them on anti-resorptives, such as a bisphosphonate or denosumab. Very high risk, we start the anabolic therapies like teriparatide. All patients, regardless of what risk category they're in, will benefit from resistance training and nutritional strategies to address that sarcopenia. Just a word about perimenopause, because I think perimenopause is having a moment now, and people are beginning to realize just how important it is, and the kind of multi-domains that it affects. So what we know, the SWAN study showed that bone loss actually starts in late perimenopause. And, big part of that is estrogen decline is driving both the bone and muscle loss. So what tells us is that, we really need to be screening for osteopenia and sarcopenia much earlier than we're doing right now. So what's the issue? So it's not that we don't know how to treat this. We know that resistance training works. We know that medication works. And so we're not looking at a knowledge gap, we're looking at a structural barrier that stops us from doing this. And part of this is because as the family physicians who get burdened with this, they have so much on their plate because, it's a time-intensive screening process. With new medication on the market, the indications and the guidelines are changing. A lot of these patients are on fixed income, and so it's hard for the family physicians to navigate the financial portions of it, and also it's hard to find time to follow up with these patients just to find out, are they doing the treatment prescribed? Why aren't they doing it? How do we overcome those barriers? And so that's one of the reasons that we established the Burlington Bone Health Clinic. It's a multidisciplinary clinic. We have endocrinologists, rheumatologists, physiatrists, and internal medicine specialist. And so what we do is we see the patient. So the patient will see a specialist. They will get their risk stratification will happen, and a treatment plan developed for the patient. So then the patients then spend a dedicated amount of time with a physician assistant. I think, and this is, I think this is very key, because, all of these conversations are not just, hey, you need to do strengthening, you need to increase your protein. Each conversation is, like easily an hour, right? So I think this physician, the time the physician assistant spends with the patient is really important, because it helps the patient understand what the issue is, what their treatment plan is, and how they're going to do it, what the importance of it is. And then after that, we've been able to provide these patients with group sessions with a physiotherapist, who talk to them about fall prevention strategies, as well as physical interventions. We bring them back to talk to a dietitian who does a deep dive into what those nutritional strategies are, how they can access it. A pharmacologist, which kind of takes them through what their medications are, what the side effects are, how to do it. And then we have a specialist that has trained in, an athletic therapist that's trained in the treatment of osteoporotic patients, right? To take them through those exercises and how they do it. It's really important that we've been able to keep this cost-free to patients, because a lot of these patients are on a fixed budget. They can't afford all of these peripheral services. And so the ability to keep this cost neutral, I think, to keep this cost free to patients is really important, and that's one of our tenets, that our patients don't have to pay for this. So, I want people to see, I want physicians to see this as not a replacement of their care, but an extension of their practice. Something that frees them up, allows them to focus on things that are somewhat more acute. So my final message to you is that fractures are loud, but sarcopenia and osteoporosis are silent. The only way we're going to change this is by early identification. So I'd really, really advise to, start thinking about making early referrals. So ideally, we want to see women over 50 and men over 70, or even younger if they're more sedentary. We want to get in early, because the earlier the intervention, the better we're able to preserve strength and independence. Thanks.
Thank you so much, Dr. Manju, for that excellent presentation. It's definitely helped kind of highlight the importance of identifying things early, like sarcopenia, and acting early. And it's amazing what you've set up in our community to help our patients. So thank you for taking the time to be here and share with us. We're open for questions now. So if anyone has questions, please feel free to ask or post them in the chat. I have a question in terms of the patients that are referred and seen. Do you have testing on site as well?
Yeah, so what we do is once referral is made, we'll contact the patient. We will arrange for all the blood work, the DEXA scans to be done. We've partnered with Wentworth Halton,
Okay.
and they've been really good at fast tracking our patients and are getting our patients seen in a prioritized fashion. So by time they're in front of the specialist, all of the investigations needed are done. So it's not like we have to like send them off, get the investigations, bring them back in. So just because just the ability to get to a physician's office is a barrier for some of these patients. So we want to limit, we want to maximize their time.
Okay. And then with the DEXA scans, are they also looking at body composition then?
The DEXA scans through Wentworth Halton are not. They're primarily for bone density.
Okay.
Just because the body composition isn't covered by OHIP.
Yeah. That's right. Okay. Great. I think Priya, you had a question, or
Yeah, I was just I'm an endocrinologist and I
okay.
have a special interest in metabolic health.
Priya, are you able to increase the volume just because we
Oh,
can't,
oh,
or
you can't
increase the
hear me? Oh,
sensitivity?
is that better?
Yeah.
No?
Yeah,
Yeah,
that's good.
okay. Yeah, so I'm an endocrinologist with a special interest in metabolic health and have authored guidelines on lipids and obesity. So the DEXA,
I,
oh, sorry, the DEXA is not something that's mainstream for metabolic health. But I am curious about the changes in Ontario with regards to access to bone mineral density. Are you all familiar with that, or I'm curious to know how that's going to impact your practices in primary care.
I'm not actually familiar with it.
Okay. Yeah. Okay. So it seems that, and maybe this is something that Jay can speak to, is that the access to BMDs in Ontario as of April of this year has changed, so that the access to repeat testing is limited, and they've narrowed the clinical judgment for follow-up BMD timing. So it's now high risk by FRAX score, but the repeat is only every 36 months, and they will only do repeat testing every 12 months, as I understand it.
Yeah, that's right.
For hypercortisolism, Cushing's, or someone who's on high dose prednisone. So even with secondary causes, they'll still have to wait 36 months. So so in terms of monitoring the response, sometimes the bone density is helpful. It's 1 point of information. But I wondered how that, how does that affect primary care in Ontario? Like, how have you been ordering bone densities?
Yeah, I wonder if one of our family physicians on the meeting here could weigh in on that. I actually have a primarily hospital-based practice, so I don't follow up on patients. I usually don't even order bone densities because I'm in the hospital. But yeah, I wonder if someone in the community can weigh in, if anyone has comments about that. Have you noticed anything, Ajay, with regard to that in the clinic?
Yeah, so it does make it a little bit more complicated just because they won't do it. They won't do it within 3 years. And so we, like I think, we try to use whatever their last bone scan is, but at 3 years back, patients don't remember, or they don't have the record of it, family, or if they've changed family physicians during that time, their new family docs don't have access to it. So That's a bit of a challenge. We're working with the hospital at Joseph Brant to for those subset of patients to try and get a fresh bone scan done.
Okay.
But it may be one of those uninsured things that there are some practices in British Columbia that do bone mineral density scans, but they do it off the registry of the pharmacare or the provincial government. But there may be some people who may be doing that privately, and you know, if there's a way of getting access to that, I think it would be very helpful.
Mm-hmm.
Yeah.
And what do y'all think about, like, I know the body composition part of DEXA is not covered. What, like, how important is that in you know, tackling sarcopenia and helping our patients stay stronger to protect their bones and prevent fractures? Like that piece, measuring that piece.
Can I take that?
Mm-hmm. Yeah.
Why don't you go first, Jay?
Bray, your volume is low again.
Oh, maybe. Do you want to go first, or?
No, you go.
No. Yeah, so it's very interesting. So in clinical trials, in obesity trials, for sure, they've looked at changes in muscle mass, but we're still not really sure if those changes, the decrease, you can decrease the mass of the muscle by decreasing the fat fibers in between the muscles, but you can still improve muscle function. So you know, with regards to sarcopenia, I always wonder what really does the DEXA tell you in regards to your muscle strength? The proof is in the pudding. How much can you lift? What can you do? And so I think the clinical approach to that is much more relevant than the BMD or DEXA scan. I think the DEXA scan, really what we should be reinforcing to patients is the functional importance, the healthy behaviors, and not, oh, I'm congratulating you because your DEXA scan shows less adipose tissue. No, we're congratulating you because you've got more engagement in healthy behaviors, your nutrition is better, and that's what you want to reward. Right, the behaviors, because patients have very minimal control over what the DEXA scan will show, but they can control their physical activity, they can control the time they spend in the gym, etc.
Yeah.
But I think it's still very useful for assessing bone health, because that is something that you can't really see unless you fracture. And I think it really is very helpful to guide therapy. So it's I think it would be very useful for those patients who are able to afford it to be able to have access to private DEXA scans, more so in Ontario.
Yeah, thank you. That makes a lot of sense.
Sur le stéthoscope de Camille et c'est beau. Merci.
I think someone just accidentally unmute themselves, but yeah. Okay. Well, that's great.
Yeah.
Any other questions? Yeah.
Just what is the greatest challenge that you have in osteoporosis management in the community, just to get the feedback from the members, because I think that's really helpful to know what the needs are. What's the most challenging aspect of osteoporosis management in your practice? I think we have to get everyone to say one thing.
Yeah.
Stephanie?
If others want to weigh in, yeah.
We can start with Stephanie and maybe
So Stephanie's actually helping us coordinate the meeting. Yeah.
How about Dr. Breen?
Anyone want to weigh in?
I see Dr. Breen is not weighing in.
Yeah.
He's got it covered.
It's probably for me thinking about screening patients that are at higher risk but lower age. You know, people with other chronic diseases, for example, or malnutrition from all kinds of, you know, malabsorption or other reasons.
So screening them, I think you're right. Those patients do deserve a bone density scan, but I think that but the treatment may not be. They will do a baseline scan, as I understand it. I still have and
Yeah,
that's still
they
based
will.
on the healthcare provider assessment. But for those, I think the key thing is to lean into the issues that are causing problems. So if it's steroids, then they should be on bisphosphonate therapy or denosumab to protect the bones for the duration of steroid use. If it's malnutrition, um, then nutrition is the way to improve the bone health. Uh, the other secondary causes that you mentioned were, I think, chronic illness, and I think that comes down very much to weight, nutrition, and certain meds that are being used. So things like Crohn's disease or patients with malabsorptive disorders. Again, leaning into the nutrition part of it is important. And if they're younger, correcting the underlying defect is more important than giving them the fracture reduction therapies may not have as great a benefit, but certainly the muscles, especially if they're premenopausal for women. So the absence of estrogen is something that could be, unless there's a breast cancer diagnosis, the absence of estrogen is something that could be replaced in premenopausal, in young postmenopausal women. That's very important for their bone health. And again, leaning into the physical activity very early on because their bones they are able to do more physical activity. They're more responsive, and being young is very protective. So the threshold for starting pharmacotherapy in those patients is set much higher.
Anyone else want to share any challenges they've had? I think for me, I mean, I see patients with their acute fracture and then not kind of being able to follow them. It's hard, but I think what happens that I've heard from other community providers is a lot of it is a time issue as well. Just being able to fit in that counseling and screening in those patients where it's not obvious, or try to target sarcopenia. I think that's something that in those 15-minute visits, it's hard to kind of incorporate. So it's really great that there is a place we can refer them to spend that time, because a lot of it is just taking that time to really educate the patients and really get into the details of what's actually needed for prevention of these fractures. Within the clinic, is there also like do physical therapists or are there like exercise therapists who will actually show patients how to strength train and do the
Yes.
different exercises?
Yes, we have an athletic therapist that
Okay.
did a course on muscle strengthening in osteoporotic patients. So we do a group counseling session with patients, and she takes them through kind of the exercises that they can do, and some patients have to modify, so she'll take them through modifications for that. So
Awesome. That's great.
Do you know if there's anything similar in Oakville?
I do not believe that there is, no.
Thank you. Such an
Yeah.
amazing initiative.
Yeah, so we want this to be, it's a pilot study, basically. It's a pilot clinic that we want to, because we're actually going to be collecting data, looking at the fracture rates in our clinic population, comparing it to the fracture rates in the community. And if we can demonstrate even a 20% decrease, that's, looking at the dollar amounts to it, I think that we can make a case to then, expand clinics like this, like to different communities. So it is a bit of a novel concept. And we really want like the Halton area to be the first place where this started.
Amazing. And if people wanted to refer, they would go onto the website and there's a referral form.
Yeah, so there's a referral form. We're also on Oceans MD as well, and we're part of the SCOPE pathway.
Okay.
SCOPE Women's Health Pathway.
Amazing. Okay. That was an excellent presentation. Lots of great information. We will have this webinar shared on our CCHOHT website. So if anyone wants to access it, it would be on the Connected Care Ontario Halton Health Team website under physician resources. And then Dr. Manju, if you have other resources you want to share with us, or if you want if you want the referral form posted there as well for easy access, we can post all that there as well.
Perfect.
Yeah. And before everyone leaves, if you could just take some time to fill out the evaluations shared in the chat. Your CME certificate will be emailed to you. Please add your email in the chat window as well. If it's sometimes we don't get all the emails, so if you don't mind doing that, yeah. And then we'll see you all next time.
All right. Thanks, guys.
Thank you again.